if you're just So if you're joining in, if you can drop in a chat group where you're joining in from, we would love to know who's on the Lunch and Learn today. And we want to welcome you all to the Mama's Voices Lunch and Learn with the PCOS Challenge. We're going to talk about PCOS and how it impacts maternal health with Sasha. So we're excited to have you all on. We know that it is midday and Hurricane Helena is like making its route right now. So we know that many have been impacted by the weather. So those that are on here, we're thankful that you're here and that you're safe. And we're going to go ahead and get started so that we can ensure that our host has time to cover all the material that is needed. So welcome everybody. Remember to drop your chat in the chat, drop where you're from, where you're joining in from. We would love to know who's on the call with us today. So this is our agenda for today as we welcome you guys on. I am the program director, or excuse me, program manager for Mama's Voices. I work predominantly in the outreach department, and I work a lot with our maternal health coalition partners who are our MVPs, who PCOS Challenge is one of our lovely partners as well, who will be hosting the Lunch and Learn today. But we will go through the agenda. We will talk about who is Mama's Voices and what is our program. I will provide the introduction of our speakers, and I will turn it over to our Lunch and Learn host, Sasha, to talk about PCOS and maternal health. So what is Mama's Voices mission? Our mission is to amplify the voices of people who have experienced pregnancy, loss of complication, especially those who have been historically marginalized. We want to ensure that all of our patient family partners and those who have lived experience are equipped to work in partnership with providers and researchers to improve maternal health outcomes. Mama's Voices, our name means maternal mortality and morbidity advocates. So we want to ensure that our advocates are prepared and trained in order to make impact with their stories and their advocacy work. Just full disclosure today on terminology that you may hear. The terms such as woman, mama, mother, mom, she, and other terms are used throughout in reference to pregnant and postpartum persons. We acknowledge and respect the variations that exist in gender identification and emphasize strongly that all people, regardless of their gender, identity, deserve the best medical care, representation and research, and validation as human beings. So how can you engage with Mama's Voices? We predominantly serve, I would say, three audience of that we support. First being our patients with lived experience or family members who've had lived experience. We have a online self-paced certified patient family partner certification training where you can go and do self-paced training to equip your story to be ready and geared and prepared for work in maternal quality care and improvement. We also train healthcare providers through our lived experience integration training, which is usually a weekly 5 cohort course where you're, as a clinician or provider, can engage on how do you engage patients in your quality improvement work? How do you recruit them? How do you work with them when you're ready to seek change in any of your efforts and practices in your healthcare organizations? And we also have our MVPs, which is our maternal health partners, our coalition agencies, which are usually nonprofit or maternal health organizations that are leading their personal mission and vision to ensure that quality improvement and patient engagement is a focus in the work that they are engaged in. Currently, these are our maternal health Mama's Voices partners. They range in different areas of support, research, maternal mental health. We have a variety of maternal health organizations that represent our MVP partnerships. So we'd love for you guys to tap in and join more about what we do. If you scan the QR code, there's an interest form to our website that you can learn more about our trainings as well as our coalition partnerships. All right, next I want to introduce our amazing presenters for today. This is Sasha. Sasha is the founder and executive director of the PCOS Challenge. It is a nonprofit organization that supports and advocates for organizations advancing the cause for PCOS patients globally. Sasha started the organization after she was diagnosed with PCOS and experienced great dissatisfaction with the availability of support resources for PCOS patients. So this topic, I say, is definitely near and dear to me also, as a PCOS person has been challenged with it as well. So I will bring Sasha on forward to introduce her panel, who will be rocking with her today, and we're excited to hear from them all. Thank you.
Thank you so much, Rhonda, for that lovely and kind introduction. I'm excited about this talk. It's an important topic, and it's an important topic in maternal health. And I, like so many of you, have been personally impacted by access to appropriate care after giving birth and during pregnancy. And one of the things that is intimately connected with maternal health is PCOS, and we'll be connecting the dots for you today. Before we do that, I'd like to introduce my lovely panel of speakers. Next, please. First, we'll have Renetta DeVos, we call her affectionately the PCOS reporter. She's on the PCOS Challenge Patient Advisory Board. Then we'll hear from Dr. Kim Hopkins, who is also on the Patient Advisory Board, but she is a researcher and a women's health nurse practitioner. We also have Dr. Catherine Sharif, who is a professor at Jefferson University in Philadelphia, Pennsylvania, and is a women's health PCOS specialist who is kind of a fan favorite in the PCOS community. So really excited to have her here to speak about optimizing our care. But first, at PCOS Challenge, we are completely patient-centered. Everything we do revolves around the lived experience of PCOS patients. And so I thought it important to start with a patient story. And Renetta has been advocating about PCOS for, I think since 2014, when we first met, and has grown, her passion has grown, and then recently had her own maternal health experience to share. So Renetta, I will turn the floor over to you so you can go ahead and share your story.
Thank you so much, Sasha, and thank you to everyone for giving me this platform to share my story on, and I hope that it helps at least one person. I heard the words that you will never be able to have children, or you may have extreme difficulty having children, and you have endometriosis. Just after I met Sasha and the wonderful folks with PCOS Challenge, and just attending that symposium and then going to the doctor and hearing those words, it helped me to advocate for myself. And that set the stage for the rest of my life until now, for really understanding what it was that I was getting myself into with having a baby with PCOS after the age of 35. So I will start with that. So I said, well, let me talk to a reproductive endocrinologist. I had learned that you want to talk to those types of doctors, not just your general doctor when it comes to PCOS. And I was able to, at that point, begin treating my PCOS, preparing myself for pregnancy. And at that time, I'd seen my RE, my reproductive endocrinologist. I was not ovulating. I wasn't even having a period every month. And so I knew that I would face some challenges. So it took a lot of work And when I say a lot of work, I mean a lot of understanding the condition, understanding that I have to make lifestyle modifications, do hormone therapy, and I had chosen to approach this naturally. And so at the point where it took about 6 or 7 years in order to get pregnant. And then once I did, I was faced with a high risk pregnancy. I was 37 years old. And at that point, it seemed like it was going well. And then I failed my 1 hour gestational diabetes test. And I had to get scheduled for a 3 hour one. I failed that one too. And at the time, my reproductive endocrinologist had recommended a really awesome OB. And I said up front, I have PCOS, and I knew that she had delivered another PCOS patient's baby. And so I knew she understood what PCOS was, but it was a challenge really working with her to understand how to treat me, high risk me with PCOS. And so I was diagnosed with gestational diabetes, and I went into this knowing that I probably would get it because I was high risk because my mother was diagnosed with it, and as a result, um, now has type 2 diabetes. And so I knew that was probably what was going to happen. But I was eating healthy. In fact, I could not eat anything bad during my pregnancy. My my baby wouldn't allow it. And so the gestational diabetes was tough because I wasn't that high in the mornings when I would prick my finger. My doctor wanted me to be in the 90 range, whereas, if you just have, diabetes outside of pregnancy, that's probably okay. But when you're pregnant, you need to be in the 90 range. And I was maybe like 101. And so I thought, well, it's not that bad. But she wanted to put me on metformin. And so I was faced with the decision, do I introduce my baby to a diabetes drug? I knew it wasn't going to be for long because doctors tell you that most times it goes away, but it puts you at higher risk for type 2 diabetes, which I already knew with PCOS that I was. But I had to fight. I had to advocate for myself. And so the solution for me, and I'm not saying that this works for everyone, but the solution for me, if you are in my shoes, was to wake up at 4 in the morning and eat to counter that insulin spike, because even a snack at 10 p.m. wasn't working. And that's how I was able to deal with the gestational diabetes. I do advocate for doulas. I had one, and she prepared for me a nice gestational diabetes friendly diet, and that helped as well. And so, as my doctor said, once I delivered my baby, the gestational diabetes went away. But after having my healthy baby girl, you can see her right there on your screen, I encountered postpartum depression, and it's sneaky. You don't really think that it's going to be something that you encounter, but it's the staying in bed a little extra. It's the not really wanting to talk to people. It's the counting yourself out when you should count yourself in. It's really sneaky. And even looking back at it now, I didn't realize it. And I took the test in my doctor's office because, and I encourage new moms to do this, just check in with your doctor and say, hey, just go ahead and test me. And I really felt like that test sort of kept me like in this certain parameter. I felt like it was way more than what they were asking me. I tested for it, but I still got up and went to work every day. And I probably still, when I had time outside of baby, caught a movie, but it's sneaky. So I had that to deal with, and dealing with work and life, it can be tough. And still making sure that you don't creep into type 2 diabetes. Well, I did at the age of 39. And that was sneaky too. Increasing A1C, your attention is to baby. No one told me that nursing would make you want to snack more. I actually lost 30 pounds while pregnant, and that sounds weird, but I did. Um, I was nauseous. I had morning sickness all 9 months, puking the whole time. And every appointment, I lost weight. But when I was nursing, it certainly came back in full force. And of course, I was an avid jogger and walker. And so some of those things I just couldn't do anymore with new baby. And so the diabetes certainly crept up. I was right on the nose, like right on the cusp, just barely had it. And my doctor said I could control it with my diet. And I went insane because knowing that my mother had it when I was I was 8 years old when my mother was diagnosed with diabetes. I had been on diabetes watch as a kid. And so I knew all the things to do. And within 1 month's time, I completely lowered my A1C. I was like a 6.4 or 6.5, I think is what I ended up being. I was 6.4 right before pregnancy. 6.5 is what I tipped into. And I dropped to 5.8 like within a month. And so today, no diabetes, no hypertension, but just yesterday, I was sitting in a doctor's office. I had to work from home yesterday. I left work early this week because I had PCOS complications. And so if they tell you the trick that PCOS goes away when you have your baby, that's not true. I still had issues just this week that sent me into the doctor for an emergency. And so it still lives today. But one thing I can say is I do it all again for my baby girl. Knowing what risk I have, I'm the different type of patient. Just being connected with PCOS Challenge, attending any symposiums or any opportunities I could. Even if you're on this this webinar today, you are ahead of the game in terms of knowing how to prepare for being pregnant with PCOS and with the maternal mortality crisis that's happening. And I live in Georgia where it's extremely high. I knew the odds that I was up against, but educating yourself is important. And I appropriately titled just my entire experience with having a baby, my 6-7 year journey, Never Give Up. And even if you're going through issues with preeclampsia or hypertension or gestational diabetes, never give up. Work as hard as you can to educate yourself about what medications you need to take, what diet you need to be on, and what support system you need to have so that you can combat this as I did. So thank you for your time.
Thank you so much, Renetta. It's truly inspiring, frustrating and inspiring at the same time to hear your story. So I would now like to introduce Dr. or bring to the stage Dr. Kim Hopkins, who will speak about PCOS. What is PCOS and what are your risks for pregnancy and pregnancy-related complications? Dr. Hopkins?
Sorry about that. Hey, just want to make sure you all can hear me.
Yes.
Okay, great. So thank you all for being here. I'm really honored to be a part of this webinar. PCOS is close to my heart. I call myself a triple threat. I am a women's health nurse practitioner, so I provide care for women and persons with PCOS. I'm a scientist, and my focus is in PCOS. And I also am a woman with PCOS. So near and dear to my heart, I eat, drink, sleep, live PCOS. And so what I want to talk about, hopefully we all are familiar with PCOS, and if not, great, that's why you're here. Overall and generally, I'll give it a brief overview because Dr. Sharif is going to go into a little more detail. but basically, PCOS is a condition of hormonal imbalance and dysregulation, and specifically, it is androgen excess, which are male hormones, and ovarian dysfunction, and is commonly accompanied by metabolic abnormalities like insulin resistance for sure and obesity. But please know that there is a lean profile of PCOS, which I do fall into. And so some of the characteristics of PCOS that you will notice is irregular cycles, which is an indication of anovulation or ovulatory dysfunction. There's also increased male hormones, like we said, the androgens, and what that shows, what it's manifested in, as you can either have a lot of facial and body hair, coarse male patterns, or also male pattern balding on the hair on the head. Another way of excess androgens is also you may see persons with cystic acne or really oily skin. And then a third characteristic of PCOS is seeing the polycystic ovarian morphology on ultrasound. So those are really, those three major symptoms are how we actually diagnose PCOS. We look for excess androgens, we look for signs of anovulation, and then we also look for the polycystic ovaries on ultrasound. And so understanding that pregnancy alone is already a diabetogenic state, we have to then now think we're going to throw PCOS on top of a condition of pregnancy, which is known to be benign, but there are things that we need to understand with a regular pregnancy, right? Again, there are different hormones that the placenta develops to help ensure that that developing fetus is receiving the nutrients that it needs, which shifts it away from the mom and puts us into an insulin resistant state or a hyperinsulinemic state. And when that happens, that's where we have this increase in potential comorbidities such as gestational diabetes, where you see 3 times more likely to have gestational diabetes or pregnancy-induced hypertension with PCOS in pregnancy. Preeclampsia is also very high and common. We look at miscarriage. Again, insulin really is the driver of a lot of these conditions. And then on top of that insulin, again, you have the diabetes, you have the high blood pressure, which then leads to the preeclampsia, early pregnancy loss. And then we think about the environment that the fetus is in. Sometimes we have a condition called macrosomia, where there's a larger growth of the fetus, or there may be small for gestational age, which puts mom and baby at risk, which can sometimes lead to preterm births, cesarean section, again, perinatal mortality, and not just, again, for the mother, but when we think about macrosomia, meaning having a large baby, trying to deliver the baby, sometimes there's a condition called shoulder dystocia because the fetus is too large to pass through the birth canal. So there are a lot of different considerations with PCOS and pregnancy, and we do need to understand that women or individuals with PCOS during pregnancy are considered a high risk. So that's really important to know and educate yourself about, and just have a relationship with your provider. Ask as many questions as you need to so that you can inform yourself on the things that you can do to decrease those risks. And PCOS Challenge is one of those places where you can receive lots of informative, evidence-based information that we encourage you to look into. And I believe that is, and so again, as far as we talk about the racial and ethnic risk factors, these are also important because we know maternal mortality and morbidity period in Black women and women of color, they have a higher risk of mortality and morbidity. And so again, you throw the PCOS on top of it, and we talk about the pregnancy-related mortality. So Black and American Indian, Asian, Native women, higher risks of these mortalities. obstetric embolism and hemorrhage. That is a very complicated condition that comes on rapidly and has a high rate of mortality. Very important to be aware of that from the beginning. We talked about preterm delivery for Black women, a 5-fold higher risk with the preterm deliveries. And then again, cardiovascular disease is very important to pay attention to pre-pregnancy, during pregnancy, and post-pregnancy because of the risk of cardiomyopathy postpartum, but also again the preeclampsia, the eclampsia during delivery. And we do know access to care because we push education, right? Talk to your provider. But we do understand that access to care in the Black and non-white communities can be lacking or not even available. And sometimes that access to care is not just the location, but it's also access to information that is culturally sensitive and lacking implicit biases, where sometimes the providers may not even know that they have these embedded stereotypes that can impact care. So these are all things that we need to be mindful of so that we can advocate for ourselves as far as ensuring that we try the best that we can to facilitate the health and wellness of our bodies, our lives, our children, and our family. Thank you.
Thank you so much, Dr. Hopkins, for pointing out those risks. And we felt it's really important to not only understand your risks before you get pregnant, but understand that sometimes those who are providing care may not understand or may not counsel the patients appropriately. So we, PCOS Challenge and Penn Medicine recently did a study trying to understand how patients were counseled, how PCOS patients were counseled. And the objective was to assess the counseling experiences of PCOS patients regarding obstetric complications and preconception management. And we included 302 respondents with a history of or attempt at pregnancy, and these were all PCOS patients. And so the key focus areas that I mentioned was preconception counseling for PCOS-related pregnancy risks, management of common comorbidities such as hypertension and diabetes, and counseling disparities across healthcare provider types and medication use. Next, please. So what we found were there are, of course, gaps in counseling for women with PCOS, specifically around preconception care. Only 52% of women receive counseling on pregnancy complications, and only 41% were satisfied with the counseling that they received. Only 5% receive counseling on postpartum complications. As you heard earlier, Renetta spoke about her postpartum depression. I too experienced postpartum depression, postpartum anxiety. C-section complicates things. And so this is an area that needs specific focus of improvement. And of course, the racial disparities. So while Black women were counseled more on certain risks, which is a positive, overall counseling remained low. So the opportunity here is for improvement of comprehensive preconception and postpartum counseling for all women with PCOS, ensuring equitable access to information on pregnancy and postpartum risk. Next, please. And so addressing comorbidities and key pregnancy complications. While 43% of women receive counseling on weight management, which is a key modifiable risk factor, and Dr. Sharif will go more deeply into this, 47% received guidance on managing diabetes, and only 25.5% received counseling on managing hypertension. And we know who hypertension impacts more, Black and brown people. Of course, just having PCOS puts you at high risk for all of these, but having a certain ethnic or racial profile also increases those risks. And under-discussed risks. So critical complications such as preeclampsia and preterm birth were only discussed 40 and 24.5% of the times respectively, and were less frequently addressed, unfortunately. So the opportunity here is to increase targeted counseling on modifiable risk factors, right? So preventative care, and to help to improve outcomes for all PCOS patients. Next, please. And also the impact of provider type on counseling quality. Counseling rates by provider. We found that the reproductive endocrinologists who specialize in infertility, they provide the most comprehensive counseling. So almost 80% of the REIs provided comprehensive counseling. Gynecologists, general gynecologists, only 53% provided this comprehensive type of counseling. And unfortunately, primary care physicians were less likely to provide this type of counseling at 35%. And the variability in counseling, patients using fertility medications were more likely to receive counseling, so almost 60%, than those who were not using treatments. So there's an access to care issue here. How many people have access to a provider like a reproductive endocrinologist who would give you access to medications and fertility treatment? And so there's a need here to expand training across for primary care physicians, gynecologists, and just across the healthcare provider spectrum. Next, please. So thank you. With that, I'll turn it over to Dr. Sharif.
Okay, thank you very much, Sasha, and thank you, Kim and Renetta. I always learn something when I listen to my colleagues from PCOS Challenge. I'm honored to be here with Mama's Voices. So I want to talk about some of the risks that make PCOS more deadly in women of African descent. And I want to talk about some things we can do to improve our health. So first of all, pregnancy is an insulin-resistant state. And I would say that most of your physicians, whoever you see, don't know this fact. And let me tell you why it's relevant. Next slide. So Dr. Hopkins went into some of this already, and I want to review it. So the underlying mechanism for PCOS is insulin resistance. So if you look at the top picture, you'll see a big fat liver there. And then underneath the liver and stomach is the banana yellow pancreas. So the pancreas produces insulin. And this may be very familiar to some of you, but I want to make sure we're all on the same page. So when you eat, you need to produce insulin because food breaks down into fats, proteins, and carbs in your intestines. Then it goes around in the blood, and then it's absorbed by the cells for fuel. But it can't just get into the cells. The carbs, the fat, and the proteins, they need something to open the door of the cell and go into the cell so that the cell can be fed. And that's the thing that does that is insulin. So let's say you eat a 100-calorie cookie and it breaks down into nutrients. Nutrients, the protein, fat, and carb go around and round in your blood, but they can't get into the cell. So then the pancreas says, oh, there are nutrients in the blood, got to release the insulin, and the cells are hungry anyway. So you release insulin into the blood, and the doors of the cells open and the nutrients go in. Now, the way that's how normal metabolism of your food works. What's different in PCOS is that you're resistant to insulin. So you eat that exact same 100-calorie cookie, break it down the usual way, and then the pancreas releases insulin. But now that insulin is not enough to open the door to the cell. So the nutrients go round and round and round some more, and the cells are getting very hungry. They're not getting food. And so the pancreas says, oh, I'll release more insulin. And then that doesn't work. And then finally, the pancreas releases enough insulin. And so what we have here on the left of your screen is hyperinsulinemia. Your insulin levels are high. You finally metabolize the food. The doors to the cells open, the food goes in, and now the cells are not hungry anymore. And then, so the job is done. The problem is that when you have very high insulin levels, they also do other things. Insulin is the most potent growth hormone in the body. So following this arrow from hyperinsulinemia to adipocytes, adipocytes are your fat cells. So insulin goes to the fat cells and it says, hey, not multiply, get bigger and bigger. So your fat cells get bigger. And then insulin also goes to the ovaries below, and it tells the ovary, make more testosterone. And then when you make more testosterone, that actually tells the fat cells, the adipocytes, to multiply. So you have many more fat cells, and they're getting bigger because of the hyperinsulinemia. So then, and as you gain weight and the adipocytes are getting bigger, that tells the body you are more insulin resistant, because if you gain weight, you become more insulin resistant. And then you actually produce more insulin, and then you produce more testosterone, and the fat cells get bigger, and it becomes a vicious cycle. You become more insulin resistant. It's very hard to break the cycle, but we know how often women have been shamed in the doctor's office. They've been fat shamed. They've been shamed about not doing exercise. They've been shamed about not eating right. It's difficult for all of us. Very few people are very disciplined and can also fight the cultural influences that we have of not being physically active, not being surrounded by good food, right? But if you're carrying some weight, doctors feel more permission to criticize you and shame you and blame you. So with this vicious cycle, what happens after time is that now you are so insulin resistant. You have produced a ton of insulin. Now you can't produce enough insulin to deal with all the food that's broken down in your bloodstream, and your sugars go up. And then one day the doctor says, oh, you have type 2 diabetes. So I wanted you to know, I wanted to go into this a little bit more because I want you to know that that pregnancy is an insulin resistant state. Don't forget, those babies that started out like the size of a thumbtack, they don't come out that way. It would be a lot easier if they did, but they come out like, 6, 7, 8 pounds and so on. And the reason we produce so much insulin is we have to make this baby grow. But so that's how you can get a tiny being to grow into an 8-pound baby. But at the same time, it puts you more at risk for type 2 diabetes because you gained weight and now you're more insulin resistant, which will make you gain more weight and so on and so forth. Next slide. The obstetric complications, Dr. Hopkins already covered this. And these numbers are off, but basically the take-home message is that gestational diabetes is over 3 times as likely, that's an odds ratio, 3 times more likely to occur in women with PCOS than without PCOS. And that is because of insulin resistance. Next slide. Okay, so how do we optimize your health before you conceive? And what I'd like you to do is to optimize your health even if you're not trying to conceive. Because sometimes in this country, when we talk about women's health, it becomes mother's health. And then we don't pay attention to women the rest of the time, just when they're a mom, when they have that role, but not when they're actually just trying to live and not be a mom. So we need to make sure that you don't have elevated blood pressures or even high blood pressure. You may have heard of the DASH diet. This is a diet where people were given a minimum of 5 fruits and vegetables a day. And when they were given that, this is not sending people home and saying, okay, I want you to get 5 fruits and vegetables a day, but actually giving it to them. Blood pressures dropped. People were able to come off blood pressure medication. So what do fruits and vegetables contain? They contain minerals, potassium, magnesium, calcium, and those are the main ones, and they lower blood pressure. And what's amazing is that we can fix this with food, but mostly we don't, for lots of complicated reasons. So if you have high blood pressure, we want to know it. Secondly, do you have an elevated A1C? And as you know, the A1C is the 3-month sugar. If you reach 5.7, you're pre-diabetic. If you're 6.5, you're diabetic. And I would like everybody to be around 5.1, 5.2. But that means when your A1C is elevated, it means you're already starting to lose control of your sugars and not produce enough insulin. We also need to screen for lipids. So I have here triglycerides and LDL. Those are the 2 bad types of cholesterol. You want to know what those numbers are. You want to make sure that your thyroid is functioning correctly. And if you do have hypothyroidism and you go into your pregnancy with hypothyroidism, your thyroid requirements increase. And we want to know what your TSH is in the 1st, 2nd, and 3rd trimester, and your OB should be checking that. And finally, one thing that we miss a lot in women with PCOS is sleep apnea. So sleep apnea doesn't just come because you're overweight. If you're overweight, sleep apnea also is higher in PCOS because it is driven by testosterone. And women with PCOS have very low progesterone. Progesterone makes us breathe faster, and testosterone makes us breathe less. And that's the perfect combination for sleep apnea and PCOS. Next slide. Okay, so how do we optimize health? We treat the insulin resistance 1, 2, and 3 with nutrition. And people glaze over, doctors glaze over, and patients glaze over when I talk about nutrition, but it is critical. And we live in a country where agribusiness has completely taken over the way that we eat. And we do not get enough fiber, and we don't get enough fruits and vegetables, and we eat way too much protein, way too much meat. And that is a result of direct marketing by the people who make sources of nutrition, such as the chicken farmers and the beef farmers. Also, when you're trying to eat well, you may believe that you're doing better with chicken than if you're eating beef, and in fact, that's not true. But the chicken raises your LDL cholesterol just as much as beef does, but the marketing from the chicken people has been very effective. And I want to go into nutrition a little bit more. Next slide. Physical activity. weight training over cardio. Don't forget, you don't have to go to a gym. If you have legs and you walk, you are using the largest muscles in your body. And if you walk, you can walk and shuffle along, or you can walk. And then I want you to think about something when you're walking. Can you press down on your toes, lift up your heel, and do it, lift up your heel enough so that the person behind you could actually read a little message on the back of your heel. And when you walk that way, you're actually engaging in many more muscles than you would if you didn't stretch your. So I want you to feel your whole foot stretching as you walk. And because sometimes that's the most that we can do is walking. And sleep is critical. We need 7 to 9 hours a night. It's essential whether or not you have sleep apnea. Our insulin, people who are insulin resistant, it's almost impossible to lose weight if they don't get 7 to 9 hours of sleep at night. You have to do it. It will shorten your life if you do not sleep. And then some supplements and medications we can talk about next. Thank you. Okay, so many supplements have insulin sensitizing properties. And one of my favorites is inositol, the combination of D-chiroinositol and myo-inositol. And this is a B vitamin. It's also structurally, it's an alcohol, but it's not alcohol. But it is a B vitamin, it's a sugar, and it is a very powerful insulin sensitizer, very powerful and safe to use before, during, and after pregnancy with breastfeeding. Inositol also increases our neurotransmitter called GABA-aminobutyric acid, and which makes us feel calmer. Vitamin D3 is a very powerful insulin sensitizer, and I urge you to continue this through the pregnancy. Please don't take D2, the 50,000 prescription form. It's not well absorbed, but D3, everyday D3 that's available in the pharmacy is. If you're taking omega-3 fatty acids, please continue. Your child will be a genius. It also lowers blood pressures. Vitamin D also lowers blood pressures, just for what it's worth. And something to think about with African-American women. Why do African-American women have higher blood pressures that are harder to treat? Well, one thing they have is lower vitamin D, because it's much harder to get from the sun. The darker your skin, the less vitamin D you have. And but vitamin D actually lowers this hormone called renin in our kidneys, which makes your blood pressure go up. So if you have low vitamin D, it might be why African-American women have higher blood pressures and that are harder to treat. Some other supplements that I don't know whether you should take them during pregnancy or not. The first 3 I'm absolutely 100% comfortable with. The other 2, N-acetylcysteine, alpha-lipoic acid, are excellent. And so are berberine, cinnamon, chromium, and so on. But nobody just knows how much to take during pregnancy. Next. Okay, and skip that, please. Okay. So we need to decrease calories. We need to decrease, which will decrease insulin. For example, you always think like, well, if I have I'm going to have a piece of cake or a muffin, my insulin levels are going to spike. But not with protein. Well, if you eat enough protein, if you eat an 8-ounce steak, your insulin levels will be through the roof. So with very high proteins, you will increase insulin. So we need to decrease simple carbs and overall calories, less meat, less inflammation. And then a word about the microbiome, and I think I have a slide on this next. Let's see if you could skip that, please. Okay, so the microbiome, as you know, if you're doing any reading these days online, the microbiome is the makeup of the bacteria in our gut, and it's responsible for just about everything, you know, from autism to myasthenia gravis to multiple sclerosis. It's amazing. The bacteria in our gut really run the show. So when you look at the microbiome in women with PCOS, you'll find that they have less diversity, which is not good. You want more diversity, more types of bacteria in your microbiome, and you want and they also have more pathogenic bacteria that actually cause problems. And so the solution is not to take antibiotics to kill, the bad bacteria. The solution actually is to have a stool transplant. So if you'd like to have one, let me know. So let me tell you, these stool transplants are just amazing. I mean, I want to sign up. I want a stool transplant from someone who's good looking, thin, and has lots of money. But what the stool transplant shows is they've been done lots of rat and mouse studies, and now in humans, in women with PCOS. You take, excuse me, if you take stool from a woman without PCOS and you transplant it into her gut, she no longer has PCOS. You can do the same for diabetes. You can reverse diabetes. There are excellent studies about depression and schizophrenia. And so, excuse me, what the stool studies tell us, not that we should have stool studies, but that we need to improve our microbiome. So how do you improve that? I would love you to improve your microbiome if you're going to have a child before your next child, because if your child is born vaginally, she will pick up the bacteria in your gut, and well, not so much in your gut, in your vagina. So those healthy lactobacillus bacteria in your vagina. But if you have a C-section, your child is going to have a microbiome with fewer healthy bacteria. If your bacteria aren't healthy, she picks up your gut bacteria, and it takes years to replace the good bacteria. But then if you breastfeed, you can make that up for that a lot. So the reason I have this photo here is that probiotic foods, I'm sure as you know, are foods that contain good bacteria and that we want to eat more of. And prebiotics are actually fiber. And we need 20 to 25 grams of fiber a day as women. And a lot of my patients will say, yeah, I eat salads, I get fiber. Well, actually, you don't, because there's almost no fiber in salads, lettuce, tomato, cucumber, pepper, and so on. No fiber, lots of vitamins, lots of water, but no fiber. And so fiber, you have to be intentional. And what I'd like you to do, I think if there's one thing that you could do right now that would change your health for the better, to take away from this talk, would be to increase your fiber to 20 to 25 grams of fiber a day. Every day, if you look in my handbag, I have a pear in there, which is 6 grams of fiber, and I have an avocado, which is 10 grams of fiber. And the reason I do them is because it's easy. I don't even like pears. I would prefer an apple, but apples are only 3 grams of fiber. So I eat a pear because that package comes with 6 grams of fiber, and it's just my job, and I eat it, and I don't have to like it. I just do it. The other thing is I loved avocados until I ate them every day, but the avocado is 10 grams. Every day I get a little wee knife out of my handbag, carve that avocado up and suck it down. So I've got 16 grams of fiber by lunchtime every day. Then I go home and I take 2 fiber gummies. That's 5 grams of fiber. Right there, I have 21 without even trying, right? I didn't try to make oatmeal. I didn't try to make beans and all that. So I just wanted you to know that because it's doable. And I think that fiber can change our life. And the prebiotics are more important than I want you to do both, but the prebiotics I think can change your life. I want you to be healthier, whether you're a mom or soon to be mom or never to be mom. And that's it.
Thank you so much, Dr. Sharif. So I see you have a summary slide here.
Well, okay. So the nutrition is probably, like I said, the most important piece. The physical activity, always prioritize weightlifting or building muscle, I should say, over aerobic activity. You've got to optimize your sleep. I know, you may be taking care of your mom, and your kid won't go to bed till 9, but
My life.
right, you work full time, but guess what? You still have to sleep 7 to 9 hours. It's non-negotiable, or you will die. Die sooner. We will all die. Metformin. I love metformin during pregnancy. Many doctors don't. I started using it in 1995 when I was reading about Italians and how they helped women get pregnant with PCOS, not using fertility drugs. And what's weird is that when my patients are pregnant, sometimes they will, the obstetrician will take them off metformin and then do oral glucose tolerance test. But the point is that metformin is keeping you insulin sensitive. And women who take metformin are less likely to have bad outcomes and more likely to be able to breastfeed. Consider some of the supplements I talked about, and you need to be screened early. Didn't mention fatty liver. Fatty liver shows up as an ALT or an AST. Those are 2 liver function tests. They're on your complete metabolic panel or a blood chemistry when you get it from the doctor. If they are up, chances are you have fatty liver. Fatty liver comes from insulin resistance, and it is absolutely reversible. But if you don't reverse it and you don't pay attention to it, it is the most common cause of having liver transplants in this country.
Well, thank you so much, Dr. Sharif. I'm seeing a lot of great comments about how well-rounded this presentation was. I'd just like to invite the rest of our guests to come on. I think we may have time for one question. And here's a really important one. Dr. Sharif, what are your thoughts on GLP-1s?
What are my thoughts on GLP-1s? I love GLP-1s, and I have been using them since 2006. They actually became available in 2006. The first one was Byetta, and this comes from the saliva of the Gila monster. And why someone was running around studying that, I don't know, but they found that it was a very, very potent insulin sensitizer, like metformin, but better than metformin. It was associated with weight loss, which is amazing. And so until 2006, I didn't have anything else but supplements like inositol and metformin to treat women with PCOS. I think GLP-1s are a lifesaver. And for those of you, you probably all know this, but Ozempic, Mounjaro, Zepbound, Wegovy, and et cetera.
Yeah, thank you. Dr. Hopkins and Renetta, if you could just come on really quickly. Yes, so we can share the slides. And Ellen asked or pointed out earlier, she asked about kind of informing patients, and we understand that an empowered patient is able to, is knowledgeable, right? So knowledge is power. And that's why we have tools such as communication guides, doctor-patient communication guides, and also and shared decision-making tools. So maybe that's something that we'll talk about more at with Mama's Voices and Preeclampsia Foundation about making those tools that we have at PCOS Challenge accessible, because it's really about, Dr. Sharif, your patient comes to you more informed, more aware of her risks or their risks, and can point out things, can identify things, and better communicate to you as a doctor things that could put her at risk, right?
Yes, yes. You know, and I was going to talk a little bit more about ethnic differences, but that, as you know, as of yesterday, the the science is still confusing, with some papers coming out of NIH saying Black women with PCOS don't do that bad. It's much milder. This is actually not true. It's all contradictory, but what I can tell you for certain 100% is if you are a Black woman, you are in most cases going to be treated differently than white women who walk into the office. And it's something I see day in and day out. I can tell. I saw it during my training. I see it now when I look at the charts and I see the drugs that Black women were given versus white women were given, whether it's hypertension, diabetes, even antidepressants. It's like, oh, I'm going to pull out the B team for this patient, or even contraceptives. For example, if you look at a clinic, white woman walks in and she wants college age and she wants contraception, she gets the birth control pill or an IUD. Black woman walks in, she gets Depo-Provera. Depo-Provera is so bad for you, it unmasks PCOS. So there is, you know, that is a certainty that we have to work with. So it's not just being a woman or being shamed for being a heavy woman on top of that, but then the racism. And if racism was obvious, people wouldn't do it, right? The whole point, it's like it's in the air. They can't see it. They can't see that. They would tell you, I would never be racist, right? I wouldn't do anything different. But the story is different in outcomes.
Well, thank you. Thank you so much. I know we're at time, Rhonda, or a little bit over time, but we can talk, our team, we can talk about this for days and still have more to talk about. So
yes, this was so well done. We appreciate you guys so much. Dr. Hopkins, Sasha, Dr. Cherise, Ms. DeBose, we appreciate you guys sharing your expertise. Each month, our goal as Mama's Voices and the Preeclampsia Foundation is to uplift our Mama's Voices partners, which are our MVPs, to be able to have a platform to share information such as this. We know that every topic won't meet everyone, but we hope that you guys continue to follow and share and connect with us so that you can see the future lunch and learns that will be hosted. We appreciate your expertise and we're grateful and just so much gratitude towards all the information that you shared. We encourage you all to fill out the evaluation form that has been dropped in the chat. We will also follow up in an email just with a debrief of the presentation today. It would include the slides because Sasha said that we can share them out. The evaluation form will be on there as well. And we will also have the information to our next Lunch and Learn, which will be October the 23rd at 12 o'clock. And it will be how to implement pillars of trauma-informed care on organizational, clinical, and patient care levels. And that'll be hosted by the Trauma Informed Network, which is one of our MVPs as well. So we thank you guys so much for your hour of lunch. We hope that you have a great week and that you are safe in the weather for the remaining of the week. So thank you all.
thank you all for giving us this platform as well.
Absolutely. Have a great week, everyone.
Thank you.